السلام عليكم. لا Good morning, everyone. Let us start with the last day of basic medication safety. Today, inshallah, we will complete our journey with the antimicrobial stewardship with the first session. By the end of this lecture, every participant will be able to know why antimicrobial stewardship, what is this program, and how can we will implement the program of antimicrobial stewardship, who will involve with antimicrobial stewardship, and what is the metrics of antimicrobial stewardship. Before we will start with the program of antimicrobial stewardship, we will know why antimicrobial stewardship is important. I will let you with few minutes with this video, and let us start complete our journey with the essential and importance of antimicrobial stewardship. So, this is the importance of antimicrobial stewardship. We noticed that in the last 20 years, we saw the increase of resistance of antimicrobial for antibiotic. So the antibiotic resistance is driven by overuse of improper use of antibiotic, and we see in this graph the resistance will increase at the last 20 years from 1980 until 2000 for MERS and VRE and QRP. This is the increase for antibiotic resistant infection. So we must make the program to improve patient outcomes, and also to reduce the antimicrobial resistance and to decrease the spread of infections caused by multi-drug resistant organisms, and also to help improve clinical outcomes and protect the patient from harm and use overuse of antibiotics. Also, we can make this program for optimizing the use of antimicrobial medicine in human and animal health to reduce the incidence of infection through effective and protect patient from a lot of infection, improve the awareness and understanding of AMR through effective communication and education and training. But before we will know what is the antimicrobial stewardship, let us know what is the antimicrobial resistance. Microorganisms such as bacteria and fungi and virus and viruses change when exposed to antimicrobial drugs such as antibiotic and antibacterial and antifungal and antiviral and antimalarial and, and antithelmintic as the result of medicine become ineffective. So the meaning real for antimicrobial is an agent that kill microorganisms or stop their growth. Antimicrobial medicine can be grouped according to microorganisms that act primary agent against. For example, antibiotics are used against the bacteria and antifungi are used against the fungi. Antimicrobial stewardship is a systemic effort to educate how can we prescribe antimicrobial to follow evidence-based for prescribing in order to stem antibiotic overuse. What is the main principle of antimicrobial stewardship? First, a collective set of strategies to improve appropriateness, and we also in the last 3 days we know what is appropriateness and who already have a role for appropriateness, minimize the adverse event of antibiotic which include resistant toxicity and the cost. So stewardship is achieved by promoting the selection of the optimal antibiotic regimen for duration and dose and also route of administration. What is the core element of an antibiotic? We have 7 core elements of an antibiotic, and they have also an effective role for the program of antimicrobial stewardship. What is they are? They are leadership commitment, accountability and responsibilities, AMS actions, and education, training, reporting, and monitoring and surveillance, and feedback and reporting. So, what is the effective role of them? The important role for leadership and commitment is delicate, necessary human, financial, and IT resource to the project. Accountability, they all have a single leader should be responsible for the program of outcome, drug experts, and actions for implement the intervention, which they are being changed when they change the drug to IV to oral and a lot of and shift the IV to oral and a lot of intervention which may be happened during around tracking and the impact or reporting if there is happened and a lot of training and education for all healthcare workers to be implement the program. I will ask you something. If there antimicrobial stewardship team in your hospital, Yes, and you are a part of it, or yes, and you are not a part of it. No, and it's planned to be in a future, or no, there is no antimicrobial stewardship in your hospital. If no, we will know in our session how can you make this program, because this is a lot of have importance in the future. How can we make a starting of antimicrobial stewardship? By a team, but how, from who this team is informed? By from physician, clinical pharmacist, infectious disease, clinical microbiologist, infection control, nurses, laboratory and quality, and patient safety. This is a multidisciplinary team must be informed. There is formed a committee, and this is a subcommittee from this is committee is a part of infection control committee, pharmacy and therapeutic committee, and quality and patient safety committee. But this is committee of antimicrobial stewardship has a function and responsibilities. What is this? First, to promote appropriate antimicrobial stewardship used among the hospital and the health system. Also, to provide a forum to continue education related to the antimicrobial stewardship for all healthcare organization workers, offer a resource for a promotion and enhancement of antimicrobial stewardship activities, track and trend antimicrobial stewardship initiatives and antimicrobial resistance. Frequency of these committees at the first of forming this committee, it must be at minimum monthly until the program is completed. After that, it may be quarterly to see what is already done and then giving feedback of this program. As we know already, this antimicrobial stewardship committee is a part of drug and therapeutic committee, pharmacy therapeutic committee, infection control committee, and also quality and patient safety committee. In addition, this committee members, the minutes of meeting must be available, and this is must be given to all these committees before, as we said, patient safety committee and infection control and pharmacy and therapeutic committee, and given to all committees as the needs. Right. What is the mission and the challenge of the of Antimicrobial Stewardship Committee? They have mission and challenges. What is this mission? To optimize the clinical patient outcome with regards to selection, dosing, and the duration of antimicrobial, while reducing the toxicity and the prevention resistance of reducing the cost. This is the mission. How can they change the challenge, achieve the mission, and meet the new standards with the limited resource? They must have or met obstacles. Maybe this be financial and the pushback from physicians because they have a resistance to pre-authorization and lack of appropriate person who will implement this project and not follow guidelines that be already bought by the pharmacy and therapeutic committee and follow guidelines with being which already for every disease. In this case, we have a role for leadership to demonstrate the value of the antimicrobial stewardship program and focus on empowering the front line of physicians to take over individual responsibility and potential strategy to improve the outcome of the children receiving antibiotics. So the key word of the role of the leadership to empowerment, share leadership, and This means delegate some of responsibilities and distribute leadership for some of the head of departments and empowerment. So how can we will start? We will start this program after we put national plan and strategies. This will plan, put regulation and guidelines to allow the physician to follow guidelines after but evidence-based to be awareness and gives them education and training to how can we implement and make a suitable process for follow guidelines and the evidence-based. After that, giving them supporting from leadership and monitoring the data. Let's start with the basic educating for all healthcare providing and the development update of the standardized medical record and review all patients have which they receiving antibiotic and review the antibiotic treatment for all patients and the develop local guidelines of pre-operative prophylaxis for all patients and pre-authorization from all health for all physician and monitoring the, the monitoring and the feedback of this antibiotic. This is the example for how can the appropriate antibiotic treatment indication and prescribe review of treatment. When the doctor starts to implement the antimicrobial stewardship, he must try the right indication for the patient according to bacterial infection, viral infection, and colonization and inflammation, whatever. And after that, he prescribes the suitable antibiotic for him, empirical treatment, whatever he will prescribe for him, and according to the new antimicrobial stewardship 4, he will choose the suitable antibiotic for him. After that, the role of pharmacist or clinical pharmacist will review the antibiotic that he already prescribed for him according to right indication, right antibiotic may be shifted from IV to oral, switching according to what is the case of this patient. After that, he will review again and again according to the date on the days of or duration of the treatment. After that, he will make a stop for treatment according to the duration that have doctor already decided to take for treatment or rewrite again or according to the culture or the treatment duration. But here, for the appropriate antibiotic for prophylaxis indication prescribed stop. For when the patient admitted for the for on operation, the doctor start to give the patient antibiotic for surgical prophylaxis antibiotic according to the policy of the hospital or the healthcare organization. He started to give the patient to write for the patient the pre-operative prophylaxis, and the patient will take this pre-operative prophylaxis antibiotic within 60 minutes or within 1 hour before the operation. And this is after prescribing, they will the role of pharmacist to make appropriateness to check the right antibiotic, right time, right duration, risk factors for the patient, and this antibiotic will stop after 24 hours post-operative for antibiotic. How can we make a monitoring for antimicrobial stewardship? This is follow up the restricted antimicrobial stewardship 4 that already bought by the Antimicrobial Stewardship Committee, and we will follow up the compliance rate of pre-operative guidelines and calculate the consumption of one of the restricted antimicrobial. And consumption, how can we will take and calculate the consumption of antimicrobial stewardship. This is according to the criteria of broad spectrum antibiotic, expensive antibiotic, and increase in consumption. Right. And also can calculate the cost of this antibiotic. So how can we make calculation for consumption of antibiotic? By define daily dose or length of therapy, or this is the one, and also by days of therapy. So what is this one? This is metrics. This is defined daily dose, DDD. What is this one? This is assumed average of maintenance dose per day for a drug used for its main indication in adults, as specified by the World Health Organization (WHO). DDT are often standardized to 1,000 patient days. So define daily dose per 1,000 patient days. This is an example for how can we calculate the defined daily dose for levofloxacin. This is prescribed for patient levofloxacin 0.5 gram for patient 500 mg per oral once per day for 7 days. Well, how can we calculate this is defined daily dose for this patient? The dose for levofloxacin is 0.5 gram dose over 0.5 gram DDD. Multiply 7 days equal 1 DDD. This is the number of DDD for levofloxacin already present in WHO for levofloxacin. So levofloxacin 750 mg per oral OD in 7 days, DDD equal 0.075 gram dose divided by 0.5 gram DDD. The number of 0.75 gram dose. This is the number of DDD of the standard of levofloxacin present in WHO. This is equal 1.5 DDD in 7 days equal to 10.5 DDD. This is a consumption of levofloxacin for this patient per 7 days. Length of therapy or treatment period for metrics for consumption of antimicrobial stewardship. This is the number of days that already a patient received systemic antimicrobial agent, irrespective of the number of different days. Therefore, length of therapy will be lower than or equal to days of therapy, because such even antibiotic received its own dot. So what is the advantage of DDD, defined daily dose? This is provides a method of measure to benchmark both within and between institution of normalized to a patient days. Quotation should be exercised when making a comparison between service and institution with different case mix can be calculated in the absence of computerized pharmacy recording by using purchasing data. The other way to calculate a consumption of antibiotic is days of therapy. Days of therapy, it means the number of days that patient receive an antimicrobial agent regardless of dose. This is mean any dose of antibiotics that is received during 24 hours. Represent one dot, it means one of days of therapy for a given patient of multiply antibiotic. It means this is a sum of days of therapy for each antibiotic of the patient that receive of all antibiotic standard to 1000 patient days. So dot it over 1000 patient days. What is the outcome of antimicrobial stewardship program? Then we have a lot of outcomes, and how can we calculate or make indicator for these outcomes? We will have indicator for patient outcome. How can we make indicator for outcome of the patient and affect the patient for this outcome? This is indicator for inpatient in hospital mortality, length of stay, or readmission for the patient within 30 days. So when we can calculate the patient the hospital mortality, we can know if this already indicators increased or decreased. This is affected patient outcome. Also, length of stay. We can calculate this is according to KPIs that calculate the number of infection that already affected length of stay. Readmission for the patient within 30 days. Microbiology outcome. This is indicators related to Clostridium difficile. This is maybe collecting data resource from microbiology data, epidemiology data, infection control surveillance, all this one affecting microbiology outcome, and this is can be calculated and increasing or decreasing. This is affecting for outcome of antimicrobial stewardship, and this is the indicator that our program already successful or not. Also, we can make an indicator for compliance with current clinical treatment guidelines, which already give indicators for antimicrobial stewardship is already have successful for your hospital or need to replan again and have defect in some process or not. Compliance with the guidelines for surgical antibiotic, and you can calculate the which department already follow guidelines before pre-operative or not, and which department using already the guidelines and giving antibiotic before pre-operative and stay for post-operative or pre-operative antibiotic same after pre-operative. Also surgical prophylaxis with the previous 30 minutes or calculate the timing before receiving an antibiotic for pre-operative or after pre-operative. Surgical prophylaxis stop within 24 hours or after surgery. This is also indicators to know this is already all physician or follow guidelines or not. This is all indicators to know your organization already following guidelines of antimicrobial stewardship or not. And this is all affecting the outcome of antimicrobial stewardship. Have you already find any defect or any decrease in your indicators? You can making continuous and training, education and training for all healthcare workers to succeed your project, for all healthcare professionals to improve your antimicrobial stewardship programs. So education program, this is a very important in your organization, as this is very important to make a lot of improvement and succeed your program to apply this and implement your antimicrobial stewardship to get your point and implement your antimicrobial stewardship. So this is already um, just a brief in how can you implement and what is already antimicrobial stewardship and how can you implement this antimicrobial stewardship. And we will take only 5 or 10 minutes, and and start with session 2 with Dr. Iman. How can already she implement antimicrobial stewardship in ICU. So thank you with you, and we will take only just 10 minutes and start session 2.
Assalamu alaikum. Good morning, everyone. Now, this is the second session for today, Antibiotic Stewardship Program. Hope you enjoyed this video. Can you see in this slide? This is the 10 years challenge. Bacteria also have 10 years challenge. Can you see the difference? Sensitivity, bacterial sensitivity completely different to antibiotic. As we know, the resistance is going increasing, and this is really a big problem. We will talk about today in this session antibiotic stewardship strategies, one of the important steps in the implementation of a successful and effective antibiotic stewardship program. By the end of this topic, you will be able to know the basic information about the antibiotic stewardship program strategies, to recognize the most important interventions that should be done uh, during implementation of the program, and to understand the clinical pharmacist role in the implementation of the program. Clinical pharmacist or the drug expert in the stewardship program is an important part and have a role in the implementation. As we know, antibiotic stewardship, today we, in the first session with Dr. Adina, we talk about what is the importance of this program, how to make metrics. As we know simply, antibiotic stewardship is a very important program to start in all hospital. It's a coordinated multidisciplinary program that highly support the effective use and rational use of antibiotics. So simply our goal, the effectiveness of antibiotic, safety, decrease the cost, decrease the resistance. We will talk about the strategies. We have two essential strategies. The first is a core strategies, which is should be available in all stewardship program. No stewardship program can be implemented without these two elements. prospective audit with intervention and feedback, and formulary restriction and pre-authorization. After that, we will talk about the supplemental strategies, which is education, guidelines and clinical pathway, combination of empirical therapy and de-escalation, conversion from IV to oral therapy, antibiotic, antimicrobial dose optimization, computer surveillance, and decision support. Now we will start with the core strategies. The first thing, which is prospective audit with intervention and feedback, what we call it post-prescription review or back-end strategy. This is simply after the physician prescribe antibiotic in a medication sheet or electronically, the clinical pharmacist will review this prescription for appropriateness and for culture, for a dosing regimen. Then for any discussion, he will contact and communicate it with the physician. That's why it's a back-end strategy. The prescription is already written, and then we will make intervention. The intervention should be documented, should be evidence-based, and will depend on many important factors that we will discuss now. As we know, the appropriateness that we discussed in details yesterday, appropriateness is important also in antibiotic. It should be done before prescribe any new antibiotic, and also should be revised almost every day regarding the duration, regarding dose optimization, adverse drug reaction, and even indication. So indication is a very important for antibiotics. This indication considered when we start prescribing antibiotic, even empirically or culture-based, indication should be also revised and follow up almost daily. This patient still needs this antibiotic or not? Antibiotic should be prescribed when there is a need, when there is approved indication for use. And this is the first thing that we revise for appropriateness. After that, the dosing regimen, which is right drug, right dose, right frequency, and route of administration. Therapeutic duplication may be two antibiotics prescribed with the same from the same group. Sometimes it's needed, but we should revise it that it's not a duplication. If there is any real or potential allergy or sensitivity, that's why the counseling is a very important step for and reconciliation for with the patient. If there is any history of allergy, especially with penicillin, so the recommendation is to make for IV antibiotics sensitivity test. Otherwise, no need. not a recommendation, not evidence-based medicine. After that, when we monitor the allergy or sensitivity for after giving antibiotic, any signs of allergy should be first diagnosed by a physician as allergy, identified by clinical pharmacist, and monitored by nurses also. If there is if there is a real allergy, so it should be reported, documented in the patient file, and also educated to the patient. Some allergies are severe and may lead to anaphylaxis, so some healthcare organization make like a red card or a bracelet, and this is will keep with the patient in case of emergency. The patient should be well educated to know that he have allergy from this antimicrobial. Also, we check if there is any drug-drug interaction or drug-food interaction with the antibiotic, and some antibiotic really have a significant drug-drug interaction. Some antibiotics, the level of drug-drug interaction is significant. It's category X, which is the recommendation is completely prohibited to use both antibiotic, or it will cause a severe harm, like in case of QT prolongation with some antibiotic like azithromycin and voriconazole. So this may be fatal and causing severe harm. So significant drug-drug interaction should be discussed with the physician. And if the recommendation, like in case of category D, to change the antibiotic should be done. Also, sometimes the recommendation is just to monitor, maybe to monitor liver function, to monitor platelets, to monitor ECG. All of this should be addressed, discussed, and monitored. Another thing which is variation from hospital criteria for use, as we discussed with Dr. Adina in the first session, one of the important elements that implementation of the guidelines and the protocols for antibiotic. These guidelines, evidence-based from the International Healthcare Organization like ITSA, or from national like here in Saudi Arabia, Ministry of Health. So this guidelines is evidence-based, and the hospital policies will be depend on these guidelines. It will be agreed in the committee, and there is a hospital criteria for use for each antibiotic according to indication. So we should also revise this appropriateness that we are on the same hospital policy. An important thing for antibiotic also is the patient weight, especially in case of pediatric patient. That's why the weight should be documented and updated with every new admission. Other contraindication, some antibiotics are contraindicated in case of the severe liver function or severe renal function, or in case of cardiac patient. So contraindication should be revised with each antibiotic. Let's talk in some details about the dosing regimen. Dosing regimen is an important point that should be discussed for the appropriateness review. The dose, frequency, route, duration, dilution, rate, and dosage form. Regarding the dose, sometimes there is a dose need to be adjusted, like in case of renal function, so the creatinine clearance should be measured. Some antibiotic like penicillin need hepatic dose adjustment. The frequency of antibiotic, sometimes according to the renal adjustment, instead of giving the antibiotic 2 times, we give it once only. Also, in some antibiotics like aminoglycosides, there is we have two recommendations, either to use once daily dosing regimen or 3 times. dosing regimen, as we know that if the patient is um, renal with normal renal function, so to use the once daily regimen is will be more safe and effective. Regarding the route of administration should be also revised. The duration, if the antibiotic is empirically, as we know that it should be revised after culture release within 48 to 72 hours. Also, with any new indication, with any side effect like platelets or change of renal function. For the dilution, the IV manual should be available for all nurses, physician, and pharmacists regarding the dilution. The dilution guideline should be available. The rate also should be revised. The dosage form. Some antibiotics could not be given um, oral, especially if there is any contraindication or patient condition that not allow. Some antibiotics are available only as IV. So after the clinical pharmacist or the pharmacist do appropriateness for antibiotic, for any intervention needed, they will discuss first with the physician. They will provide the recommendation. The important step after that is to document this drug-related intervention. For the drug-related problem or intervention, it could be no indication for the antibiotic. Like some antibiotic, when patient admitted, it's written as empirically, then the patient improvement or there no more indication for antibiotic, or there is a culture, so one of them at least should be de-escalated. Maybe no drug ordered for medical condition, like in a specific infection, and there is no drug written, no antibiotic or antiviral. Maybe the patient need antiviral or antifungal, and it's not written. So the recommendation from the clinical pharmacist to advise for to start empirical antifungal or antiviral. Maybe there is inappropriate drug selection, like in case of medication that contraindicated in case of renal impairment or liver impairment or cardiac patient. Maybe it's a therapeutic duplication. One of the important recommendation for the intervention to discontinue antibiotic, either for de-escalation or for adverse drug reaction or to decrease the resistance. Um, the recommendation may be for drug medication recommended, alternative recommended, like in case of non-availability of certain antibiotic, or this antibiotic is not suitable for this patient. Another thing, dosing calculation with weight or according with patient weight or according to the indication, because sometimes antibiotic written in a dosing regimen different according to um, indication. Another thing which is an important intervention with in the antibiotic stewardship is a dosing optimization. Sometimes the dosing regimen for antibiotic is arranged. So in which basis we discuss if this dose is appropriate or not according to the patient situation. Sometimes we advise to increase the dose to the maximum dose. Sometimes we advise to decrease the dose. Maybe there is a high risk for adverse drug reaction, like in case of elderly patient, for example, or for a debilitated patient, or low with low weight. Also, an important intervention that some antibiotics just need to make it extended duration, like in case of piperacillin tazobactam, the guidelines recommend to use the extended antibiotic infusion rate. because the effectiveness will increase, and there is a documented evidence in the literature that it will be decrease in the mortality, improve the effectiveness, and also decrease on the resistance, because we will use the same dose of antibiotic, but we will increase its effect. Also decrease in length of stay. Another recommendation for the beta lactams in case of meronam, for example, instead of using the duration of infusion 30 minutes, we recommend use it from 3 to 4 hours. Another important point also, some recommendation to use a continuous infusion of antibiotic. All of this should be discussed. Better to implement through a protocol or a policy and document it as intervention. Another thing which is incorrect protocol or stage of treatment, like in case of differences, in case of empirical antibiotic for sepsis, the policy for the hospital, which is based on the international guidelines or national guidelines, there's some antibiotic specified to use in case of empirical antibiotic. Some other points like prescribed antibiotic not administered for any reason, lab or diagnostic test indicated not ordered. Maybe we can suggest to make liver enzymes test to monitor, because there is a recommendation to monitor the liver function after using antifungal, for example, or in case of some other medications that increase the risk of QT prolongation. So we recommend to use to monitor through ECG. If the patient experience adverse drug reaction, for example, severe allergy or thrombocytopenia or QT prolongation or increase in liver function, all of this should be monitored, documented, analyzed, and educated to the patient. Drug-drug interaction, IV to oral switch, we will discuss later in the next few slides. Renal dose adjustment, the creatinine clearance should be calculated by the clinical pharmacist or the pharmacist. In case of hepatic dose adjustment, antibiotic de-escalation is an important intervention in the antibiotic stewardship. The de-escalation generally consider more than 1 point, like de-escalation could be with the number of antibiotics. Instead of using 3 antibiotics, now we will use 2 or 1. De-escalation of the spectrum after starting with broad spectrum antibiotic and the culture release, then we will use narrow spectrum antibiotic to decrease the resistance. Another thing also to decrease the dose, instead of using the maximum dose of the antibiotic, we will decrease the dose to optimize the dose, to decrease the resistance, decrease the side effect, and also the cost. Any medication error or near miss of antibiotic, like other medication, should be documented, discussed, reported to quality department. Some drug information requested or provided by clinical pharmacists. All of this intervention or problem related to antibiotic is an important intervention related to the appropriateness of antibiotics. One suggestion or a recommendation during documenting of our intervention as a clinical pharmacist, to document the clinical significance, expected outcome, and acceptance. This will be important during the monthly report, or during if we do a research, like what is the expected clinical significance of this intervention? Is this high clinical significance or potentially severe, moderate, or low clinical significance? The expected outcome to enhance the effectiveness, therapeutic effect, to decrease the adverse drug interaction, cost, maybe 1 or 2 or all expected outcome could be happened in one intervention. Important intervention to document that the acceptance. You should document is your recommendation or intervention accepted by the physician, rejected, or modified. The unknown acceptance may be if the patient transferred to another hospital or to another ward, or there is any pending for discussion with the physician. All of this, if you can document, it will be better and complete intervention. Now we will go to the second part of the core strategies, which is formulary restriction and pre-authorization. Now it's different from the back-end strategy and checking the appropriateness. Now the physician will prescribe antibiotic, but there is a restricted form. This restricted form will be revised by a clinical pharmacist, and the pharmacy department will not dispense this antibiotic, and so the patient will not administer this medication, this antimicrobial, unless this restricted form is completed, revised, and agreed by clinical pharmacist and the consultant. Also, maybe according to hospital policy and availability of ID physician. So, restricted antimicrobial agent, it's an agent which require prior to dispensing authorization or approved protocol by the Antibiotic Stewardship Committee. The ASP member, which may be an ID physician or a clinical pharmacist, should approve this antibiotic in the restricted form. Then the pharmacy will dispense it and the patient will administer this antibiotic. Right. What about the first few doses? It's mentioned in all guidelines for because patient may be admitted with sepsis, so the antibiotic should be given within less than 1 hour, and this will affect and decrease the mortality of the patient. So no time to make a restricted form or to sign by a clinical pharmacist or ID physician. Maybe it's in the weekends or the night shift. So the first few doses or first dose according to hospital policy could be dispensed from pharmacy department and given to the patient. Then the restricted form will be done by physician, prescribed by physician, revised by clinical pharmacy, and any changes or intervention will be documented and discussed later. How to make this restricted form and how to make a restriction for antibiotic. On which basis this antibiotic will be listed? There is no magic restricted form, or it will be simply one form with uh, some antibiotic in all hospitals the same, but this is not the truth. Okay. For example, this is a restricted antibiotic, antimicrobial from the Saudi National Guidelines, MOH. They mentioned some antibacterial, antiviral, antifungal, antiprotozoal as a general. So we can take our reference from national antimicrobial or international guidelines and according to policy. The first important thing, if the antimicrobial is not available in our formulary, so we cannot put it in our restricted form. It's nonsense. Another thing, if the antimicrobial uh, from the experience or from the report, there is no misuse of this antimicrobial, so no need to put it in unrestricted as a restricted agent. So generally, restricted agent is a broad spectrum or antibiotic with misuse or new antibiotic with unknown experience or maybe high cost antibiotic. All of this antimicrobial should be put in the restricted list. For example, you can make your restricted list in your healthcare organization. Maybe no need to put antiviral at all. There is no misuse of antiviral. Antifungal, maybe we can put only ecocandin. Some hospitals put voriconazole to make a restriction from other azole. Antiprotozoal, some antiprotozoal not available at all in some hospital. Other hospital when it's available, but there is no overuse, so no need to prescribe it. The same with antibacterial. Um, some hospital no need to add any antimicrobial, which is local, like miflosin. It's a local antibiotic. How to design a restricted form? Important point that needed for any healthcare organization to implement an effective and successful antibiotic stewardship program. This is simply a restricted antibiotic form contains the main information needed. First of all, we should specify the antimicrobial needed, if it's antibacterial, antifungal, or antiviral. So we will mention a list ready and the physician will just make a sign which antimicrobial. We need also to save the time for physician for using this list. So we encourage them to use it without losing of their time. Indication why we use this antimicrobial. It's for initiation or for continuation. Is this culture, it's empirical or it's a culture based? If there is empirical, why it's empirical? If there is any suspected sepsis, for example, so the diagnosis also is needed. If there is any clinical data that I can help to save time, we can mention that this patient have a fever or have laboratory data like CRP or white blood cells, or there is any X-ray details that suggest this patient have a pneumonia or sepsis. All of this indication for using empirical antibiotic. What is the diagnosis of this patient? Important thing to put or to mention the role of inpatient pharmacy. This antibiotic dispensed by which pharmacist, so we can monitor and audit the restricted antimicrobial. Now we already talked about the core strategies, which all antibiotic stewardship program should contain these two strategies. Now the second part, which is a supplemental strategies. Supplemental strategies contain some points. First of all, education. Education is important in stewardship program, but if used alone, have only marginal effect on implementation of rational stewardship program. So you can put it as a supplemental strategy, but you cannot depend on it alone. Second, guidelines and the clinical pathway. It's very important to put a clinical pathway and the guidelines. It's need a team. It's really will make a magic step for implementation. You make standardization for your hospital protocol. Combination of empirical therapy and de-escalation strategy, very important and critical. Should be revised all the time by physician and the clinical pharmacist and pharmacist. Maybe if it's done daily, it's the ideal, but according to availability of ID physician or a clinical pharmacist, de-escalation should be considered all the time with any clinical improvement, with any culture released, with any side effects appear. As we mentioned that de-escalation may be in the spectrum from broad to narrower spectrum antibiotic, de-escalation in the dose from high or maximum dose to lower dose, de-escalation in the number of antibiotic, 3 or 4 antibiotic, then to 2 or to only 1 antibiotic. Conversion from IV to oral therapy, it's important, decrease in the rate of infection, decrease in the cost, but also need some specification or a patient condition should be considered. Usually in a critical care area like ICU, using oral antibiotic is not recommended. The patient may be in unstable, shocked, the GI tract not working properly. So mostly we use IV. Also in some indication like meningitis or sepsis, the intravenous antibiotic is recommended from the guidelines. Antimicrobial dose optimization should be considered and revised on daily basis, either to use and optimize the dose of antimicrobial, to adjust the dose with any changes in renal function, for example, also to consider using the extended release antibiotic in case of the Bracillin, Tazobactam, and Carbapenem, to use the infusion rate extended within 3 to 4 hours instead of 30 minutes. Finally, using computer surveillance and decision support will highly help the implementation of stewardship program, because all the data or the guidelines will be on the system. If the system can automatically, especially if it's electronically system, automatically make discontinuation for antibiotic after 48 to 72 hours, so this will really help. Also, if there is a restriction of antibiotic should be done electronically, like in case of some few restricted antimicrobial should be prescribed by only ID physician or ICU consultant or revised by clinical pharmacist, it will be an easy step if it's done electronically, and will save really the time for restricted form or for revising and signature on the paper. So all the time we consider shifting from IV to oral if the patient situation allow us. If the patient tolerate oral medicine, if the oral option is available, because some antibiotics have no oral option, or maybe the oral option is not is available as a medication but not available in the hospital at that time. So all the time you consider if there is a possible switch to oral, and also consider if this antibiotic still needed or not. So also you can consider to DC antibiotic. IV to oral switch also cannot be implemented if the patient is not taking anything by mouth. The patient should tolerate the enteral feeding, and we should confirm that the oral absorption is not compromised. One of the important things also that there is a list of antibiotics that the bioavailability for the oral option is really similar to the IV option. So this is important thing also should be considered. Now we will start to discuss some specific antibiotic, like in antifungal. Antifungal, there is azole, like fluconazole, voriconazole, and there is ecocandin. Just important thing during the appropriateness, we can see here 3 types of ecocandin: anidulafungin, caspofungin, mycamine. All the time when this medication considered or starting, the clinical pharmacist should check if there is a loading dose prescribed or not. Okay, so the loading dose for anidulafungin and for caspofungin will be given one time only, and then the maintenance dose will be started 24 hours. For example, anidulafungin will be given in a dose 200 milligram for one dose only. After 24 hours, the maintenance dose will be 100 milligram. If there is any renal impairment, no adjustment needed by in case of anidulafungin. Okay. For the caspofungin, also there is a loading dose which is 70 milligram, only one dose, and after 24 hours we will start 50 milligram. The dose will be every 24 hours. Here also every 24 hours. For the micamine, no loading dose, so we will start with the maintenance dose, which is 100 milligram every 24 hours. All of them, no need for renal dose adjustment. Okay, this is regarding the ecocandin. Now we will go to a case of a patient who is started meropenem at a dose 1 gram Q8 hours. Okay, so to do appropriateness for this patient, what we can do? First of all, we will check the indication. The patient admitted with sepsis, so a broad spectrum is suggested by, recommended by physician to be given within upon admission, less than 1 hour from admission to decrease the mortality. Okay. First of all, we check the indication. Okay. Then we can check the dosing regimen. The dosing regimen, we will check first the renal function. If the renal function is normal, yes, we can give 1 gram Q8. After that, we will check if there is any renal function impairment. We calculate first the creatinine clearance and we'll calculate the dose. If there is any degree of renal impairment, the dose could be decreased to be 1 gram Q12 or 1 gram once daily. If there is a patient on, if the patient on dialysis, so the dose on regular hemodialysis and CKD patient, so the dose recommended is to give 500 milligram once daily and 500 milligram after each dialysis session. Okay. Another patient, atigacycline, tigecycline antibiotic is recommended by a physician to prescribe. As we can see here, tigecycline 50 milligram IV. Tigecycline, when first prescribing, we need to check that there is a loading dose prescribed. The loading dose is 100 milligram for one dose. Then we will start the maintenance dose, which is 50 milligram Q12 hour. One important thing that you should inform a physician and you should educate nurses that the first maintenance dose of tigecycline should be given 12 hours after the loading dose. Azithromycin. Azithromycin, important drug-drug interaction. We should check QT prolongation, especially for patient with cardiac disease, patient elderly, if there is any electrolyte imbalance, especially hypokalemia or hypomagnesemia, if there is any other medication that also decrease that make QT prolongation, so we should recommend a QT ECG and measurement of QT prolongation. Now this is the end of our session today, Antibiotic Stewardship Program, which is a very important part in the medication safety. I think thank you very much, and we are looking forward to see you in later in different courses. Mr. Alaa, please, if you want to close the course. Once we are done.
السلام عليكم ورحمة الله.
I want to thank the academic affair for the support, Mr. Alaa. Thank you very much.
Thank you, Dr. Dina and Dr. Iman. It was a very fruitful course, and thank you for this big effort that you give to introduce this course. Thank you a lot.
Thank you.
Thank you for Mr. Ali, and thank you for all participants. We are hoping to giving you all informative information, and I hope we already getting you our point. And thanks for your supporting for you. And we are hoping to get our journey to get all information for all participants. Thank you, Mr. Ali.
Thank you a lot. Thank you a lot. Thank you a lot. جزاكم الله خير دكتورة دينا ودكتورة إيمان. ما شاء الله عليكم، كعادتكم مبدعين، ما شاء الله عليكم. شكرا. الله يجزاكم خير.
شكرا.
Okay, thank you all participants. Now we الله يخليك. Now we end our course for medication safety. Inshallah, you will receive the certificate by your email, inshallah. And for CME hour, inshallah, please contact with us. Or if you make registration already, خلاص, we'll inshallah send the CME hour. Thank you a lot. Assalamu alaikum. Mr. Ali, خلاص, you can close the webinar, please. Mr. Ali? Mr. Ali?